got one of the other big dogs in POCUS from across the pond, Dr. Antonio Riera, coming from the very prestigious Yale School of Medicine, heavily involved in PEM POCUS. As I always make reference to the American group that I'm part of, P2 Network, he's one of the key players there and always has some really, really interesting cases. So we're really lucky to have him, what is for him this morning. So I'll hand over to Antonio. Thank you.
Thank you so much. Excited to be here. Dave, if you don't mind just looking, if there's chat or comments, please just let me know. So yeah, a little bit about myself. I'm a pediatrician, pediatric residency trained, then did pediatric emergency medicine fellowship in New Haven. And so I'm actually not ultrasound fellowship trained. It's something that was relatively new around that time, which was 2010 when I graduated. And I just happened to stumble into POCUS because I did one fellowship project that was related to ultrasound evaluation of veins, peripheral veins, just thinking about access issues in toddlers and infants. And then that snowballed into two additional projects that I just got lucky to be involved with. And so over time, I picked up the probe more frequently during shifts. And when you start to grow in terms of your POCUS growth and what applications you feel like are applicable for you, you sort of watch a video, listen to a lecture, read an article, and then try to apply that and do an educational scan. And then over time, those educational scans turn into clinical scans, and it's such a powerful tool and indispensable, especially in acute care settings for kids. So I really love this talk. I call it Riera's Believe It or Not, Game-Changing POCUS Cases, because these are some of my favorite cases that have really solidified my desire for teaching and showing others how great POCUS can be. I'm just trying to, for some reason, won't go to the next slide. There we go. So I had to do a little homework for the Ripley's Believe It or Not. So Robert Ripley, I don't know if you're familiar. It's a franchise in the United States that showcases bizarre and unusual and extraordinary facts. And Robert Ripley was a cartoonist, an American cartoonist. And in 1918, he worked for the New York Globe, and he published a paper or a panel that was actually titled Champs and Chumps. So it was about sports. It was about odd moments in sports and sports achievements. And then the readership loved it. And so they wanted more. And he expanded it into, instead of just Champs and Chumps, he expanded it into Believe It or Not, and went beyond sports to include strange and incredible stories. And he was a bit of an adventurer and a traveler. So all these things that he learned from going abroad, he put into this new column called Ripley's Believe It or Not. And so with that, we will jump into Riera's Believe It or Not. We'll start with a warm-up case. I think this is a fairly straightforward case from a clinical standpoint. It's a simple knee scrape. So this was a 32-month-old boy who fell and scraped his knee, had a knee injury 5 days before presenting to our emergency department. And the main reason came in was due to a new fever, pretty good fever, 39.8 degrees Celsius. Not surprisingly, he was limping, and he had a history of febrile convulsion, or we call it a febrile seizure. So in this case, I think the mother actually brought him in to be checked out, not so much for the limp, but she was worried that he might have another febrile seizure, which he didn't. Regardless, he came, and this is what his knee looked like. So you can see it's pretty swollen. There's a large scab over here, another scab over here. There's some patchy erythema. It's warm to touch. And you could move it. You could passively flex it to about 90 degrees with a little discomfort. So did have some range of motion that was intact. So I'll tell you what we did. We got some labs, which were all abnormal. So CRP is very high, 72. Leukocytosis with a pretty high white blood cell count, and the ESR was also pretty high. So what would be your next step in your algorithm for a patient like this? What do you get? What will your team typically do?
I think I worry in our institution, you could try an image with x-rays and then not know which way to, the radiologist's going to, sorry, the radiographers are going to get wound up in our PED because someone wants a bit of femur, a bit of knee, maybe lower down. I
Right.
suppose, you're wondering, is it going to capture what you need? So I'm already sending somebody up the corridor to go and get the machine for me. I'm warming the gel and
Yeah.
I'm telling
Excellent.
ma'am that we'll figure this out in the next 90 seconds and everything will be fine, to be quite honest.
Yeah, excellent. And X-ray for a kid like this, it's unlikely there's a fracture, and if there's a fracture, it's probably like a minor conservative avulsion type injury. So for knee effusions, which is what we really want to know, right? Does this kid have septic arthritis or other? X-ray sensitivity to look to find fluid in the knee joint is pretty limited in pediatrics, probably about 60 to 70%. So, as Dr. McCurry would do, we grabbed our ultrasound machine and we started right over the suprapatellar bursa. So this is one of the easiest scans to do because it's literally a single view. Um, and let me see, why is this video not playing? There we go. So we have the indicator here. So the head of the patient is over here. There's the indicator on the probe. So we have distal femur. We have epiphysis because this is a 32-month-old. We have the epiphysis here, sorry, the physis here. This is distal femur. This is metaphysis over here. And so soft tissue. We have a patella that's starting to come into view. The patella is very superficial on the screen. And this isn't a perfect scan because the quad tendon, you're not seeing it very crisply or clearly until sort of the beginning right there. But what we want to see is the quadriceps tendon going into that patella, into that kneecap. And this area here is the suprapatellar bursa. So the suprapatellar bursa directly communicates within the knee joints. So any pathology intra-articular, be it a hemarthrosis after trauma or knee arthritis and knee effusion for medical causes, you'll see a fluid pocket develop under the quad tendon here. And so this patient didn't have any fluid in the knee joint. At this time, we were repeating a lot of these images with radiology, so we had radiology take a look. And this is a um, very nice example of just you, especially when you're starting out, getting a contralateral view. So you're basically the left knee is a natural control for the right knee. So this was comparing the unaffected knee to the affected knee, and you can see the structures essentially look very similar. Curiously, also, there's no large area of cellulitis over here. The muscle fibers look intact. So at this point, we really don't have a great diagnosis. We move the probe over to scab number 2, the smaller scab, and this is what we see. So we see a little bit of tendon here, soft tissue, some part of bone with some shadowing deep to it. And then what do we think about this here?
Uh-oh.
Yeah, so I think probably more than just the scab itself. We look we this we refer to as acoustic shadowing, and it's complete acoustic shadowing. It's kind of like a gallstone or an appendiculith. So, child had an X-ray. We have patella starting to ossify in a 32-year-old, and we have an additional lesion that's very calcified, which ended up being a rock or a pebble. So this POCUS was really impactful in this case. There was no joint effusion. We unfortunately have had some patients who have had similar knee exams with high fever and abnormal labs that either have a prepatellar bursitis or a knee cellulitis that with consulting services that get involved have had sedated knee arthrocentesis. If they We typically don't sedate our older kids, but the younger kids sometimes we'll do a little sedation for, well, anxiolysis, midazolam. And we've done that, and it's a pretty painful, uncomfortable procedure, and the tap has been dry. There's been no fluid in the knee joint. So I look before I tap, just like same as for skin and soft tissue. Look before you do any IMD procedure. But in this case, there was no indication for arthrocentesis because there was no fluid in the knee joint. That SP bursa looked great. You were able to identify a superficial foreign body that was not apparent on your first scan. So you sort of, you're only going to be able to see where you scan. So you have to be very mindful about where you're going to put the probe. And yeah, so the patient had removal of that nidus of infection and did well on oral antibiotics. And so for comparison purposes, this was a 17-month-old that actually did have septic arthritis with a negative x-ray that had no fluid in the joint on the x-ray. And you can see this nice pocket of fluid in the suprapatellar bursa under the quadriceps tendon here. Again, metaphysis, physis, epiphysis here, and then the non-ossified patella in a 17-month-old is over here. So incredibly helpful. Any questions on that one? All right. So the next case is called She Needs a Neb. This is part of the case series titled Everything That Wheezes Is Not Always Asthma, which is something we like to talk about in pediatric emergency for sure. So this was a 4-year-old girl who was actually visiting from Nigeria with her family, who presented with difficulty of breathing. And this one's important because we didn't have a pediatrician to sort of call or anything in the medical record to have, a sense of past medical history. And so we're really going by pure patient history and physical exam to know what the course of treatment and management would be. And so she was coughing, and she was breathing fast. The parents looked at her. They said she was breathing fast, so they had her come in. Also had a tough time sleeping the night before. I tend to find myself asking this question often for kids with cough and difficulty breathing, because if they sleep great the night before, it's probably not as concerning. But if they're up all night with cough or can't sleep or have to position themselves, I feel like that's, to me, is more of a red flag. So couldn't sleep well, cough, fast breathing. The vital signs, they look pretty normal, except the respiratory rate is certainly elevated. She has some tachypnea, some dyspnea, potentially some grunting. She's wheezing, which is what the triage nurses picked up on. She had a murmur. And her liver tip, if you really examined her well, was about 1 to 2 centimeters below the subcostal margin on the right side. So since this is a POCUS talk, what POCUS would you like to do for this patient? Lung POCUS, abdominal POCUS, cardiac POCUS, other POCUS.
I think all three of those would be very, very helpful.
I do too. I tend to we start in the heart. We say let's just start with the heart when we're talking about undifferentiated patients. And I have found that unexplained dyspnea is it's a pretty good indication to check the heart for pathology. So here we have a parasternal long axis view. Dave, do you want to have somebody on the call interpret it? Or how do you want me to, or do you want me to go over it? How do you want me to?
Yeah, no, I think there's a few people of sufficient experience. Certainly, I could start off, but I think go on. We've got plenty of people. I know.
There's a lot of clips, so maybe somebody wants to tackle this one, and I'll go through the rest.
Yeah, no problem. I'll do this one then. Go on. Lead by example, so apparently. Grand. So so you got a parasternal long, pointing the other way to how I normally do it. So is this your indicator's on your left here, so it wouldn't be for me, but we get that. So yeah, you're getting obviously a view here of left atrium, left ventricle, ventricular outflow tract. We can't see too much in the near field of RV, and we can essentially appreciate a kind of dilated left atrium, what looks to probably be a dilated left ventricle. Function-wise, hard to see in the clip, obviously, but it looks sort of relatively adequate, possibly a bit reduced, I would say, in terms of that anterior leaflet of the mitral valve coming up. Um, can't appreciate any obvious kind of pleural or pericardial effusion in this view, but
Mhm.
yeah, looks dilated, right?
Yeah, that left atrium was strikingly enlarged. And that's part of our cardiac POCUS. So function, effusion, and then relative chamber size. So if we ever see an atrium that looks like that, for sure, something is not right. And I think on this apical 4, so right ventricle, left ventricle, right atrium, and again, the biggest chamber is the left atrium. We can get a better appreciation of the function being a little bit diminished. It's just the squeeze is a little bit down. That mitral valve leaflet's not hitting the septum. And there's a trace, the start of a trace pericardial effusion here, but that's not the problem for this patient. And then what I like to do after doing a couple of cardiac views is turn to the vena cava. Just if you're worried about symptoms of heart failure and function, and you can see here this patient's vena cava. It's very plethoric. I tend to not measure or put it on M mode or anything like that. I do gestalt visual inspection, visual assessment. The patient is breathing in. There's no collapse with inspiration. This is the hepatic vein, so this is the area that we like to take a look. And so this would be a non-collapsible vena cava in the context of this patient, concerning for some heart dysfunction. And some fancy person that wasn't me put a color Doppler over the mitral valve. They actually did a really nice job with the gate placement. And you can see this stream over here of blue and yellow is a great example of what mitral regurgitation is going to look like on an apical 4 view. So we have a 4-year-old from out of the country with difficulty breathing and some wheezing, and some cardiac findings on exam too, but found to have depressed LV function almost immediately on our initial assessment with a dilated left atrium, a plethoric vena cava. And the cause of her unexplained dyspnea was actually cardiac and not respiratory, even though she was wheezing. So we got cardiology involved pretty quickly. She eventually had mitral valve replacement surgery, and the thought was that it was more likely a congenital valve problem and not rheumatic fever. Anyways, that's what the assessment was, sort of given the based on the inpatient care and the postoperative notes. And she's doing well. All right, the next case is a case of long-standing chest pain, which is probably the lowest yield in indication in pediatrics to find some cardiac pathology. Usually it's not the heart when a pediatric patient complains of chest pain. However, since medicine is difficult and imprecise and tricky, I present to you this case of long-standing chest pain, which actually was cardiac in etiology. So this was an adolescent. He was 16, and he had pleuritic chest pain for a couple of months. Worse when he took a breath in. He was seen at another hospital, when the symptoms started to develop. Was told probably had asthma. The patient did not have a past history of asthma, but they sort of empirically felt that it was likely asthma. And they started on some beta agonist albuterol therapy. And he was also instructed to take ibuprofen for the pain. Neither was helping. Also had the nonspecific viral symptoms like cough and headache and a poor appetite, but he never had a fever during this time. And so this was the physical exam, had basically stone cold normal vital signs, had some reproducible chest pain to palpation, no murmur, no rubs, no gallops, no JVD. And this patient was seen at midnight at our hospital. So, turnover, shift time. This is a fairly low acuity triage patient most of the time. We tend to get EKGs just because it's a cost-effective way to, not miss a serious pathology like pericarditis and myopericarditis. And this was the EKG for this young man. There's P waves. Axis is okay. There's no real hypertrophy anywhere. STs look pretty good. Can anybody see anything that's off with this EKG? The heart rate 72. Uh, it's not an exciting EKG. At least it wasn't to us at first. And luckily, the young man had an X-ray done, and this was the X-ray when initially complained of symptoms 2 months prior, and then this was the X-ray. Again, chest pain, headache for 2 months. So usually a lot of our staff kind of roll their eyes at patients with these chief complaints. So this X-ray is what prompted the cardiac POCUS to be done, and this was one of these depend moments. I don't know if you use depends over in the United Kingdom, but those are adult diapers in the US. And so we have, yeah, Dave, does somebody else want to do this one?
We've got loads of good people on the call, but if I have to pick one, Kate, go on, you pick this one up. This is very much your bag of things, I reckon.
I assume you're talking to me.
Yeah.
So I assume it's a subcostal view with a massive pericardial effusion and
Right.
potentially some signs of RV unhappiness suggesting tamponade.
That's beautiful. Okay. Yeah. You can see, you have to, end diastolic RV collapse. So you almost have to catch it just right when the mitral valve is open and see if that right ventricle is bowing in. We know this effusion didn't just happen over the course of 2 hours, just based on the vital signs. But you're right. This is the largest pericardial effusion I've seen at our institution. And again, completely normal vital signs. And so as we're fanning through here, this is a parasternal short indicator to the right here, and you get a great sense of the circumferential nature all the way around the heart of this pericardial effusion. And Kate, since you did such a nice job with that parasternal short, what do you think about the right ventricle here with this apical 4?
So on the apical 4, it's not it doesn't look as bad, I would say, comparing to the subcostal and the short axis. It's more being squished from the top, from the apex, rather than from the sides, which you would normally expect with the kind of cardiac tamponade situation. Plus,
Yeah.
as you said, it developed over 2 months rather than 2 hours. And with the normal vitals, we probably have time to call the cardiologist rather than sticking the needle straight away.
Exactly. That was our thought process exactly. You get a sense of maybe the RV apex here is bowing in somewhat, but you're right. That thought process was spot on. Something that we didn't appreciate at the time on our POCUS was a lesion in the right atrium. This ended up being a right atrial thrombus that was seen on the echo. The echo that was done within like half an hour of our POCUS showed right atrial collapse is the finding that they saw, which is an earlier finding for tamponade, and systolic right atrial collapse. And they saw the thrombus as well. And the other thing you can see is these tiny little bubbles going through the right side of the heart. So this patient is appropriately getting IV fluids and a saline bolus to maintain preload and to sort of counteract that pressure from the pericardial effusion. And so, that question? No. And we move on to the vena cava. This was the vena cava view for the patient. It was hard to get a perfect, textbook coming under the liver. You can see the pericardial effusion here. It's so big right there. But sometimes when you have a tough time with the long axis, you just get a short, just vertebral body. Here's the aorta. A vena cava shouldn't be twice the size of the aorta, and this isn't changing at all with respiratory variation. So another plethoric vena cava that's not collapsing. So on this patient who by all intents and purposes should have had nothing too serious going on, actually had a quite large pericardial effusion, some RV collapsibility, really helped to expedite care. We had the cardiologist, and to be honest, we had this patient admitted within an hour to our ICU where a sedated pericardiocentesis was done. They removed a liter of serosanguinous fluid, and the etiology for the pericardial effusion was a mediastinal mass with a sarcoma that was diagnosed on CAT scan inpatient. So Beck's triad, so Claude Beck, 1935, came up with the 3 most likely clinical findings that you would see in the context of cardiac tamponade. Hypotension is present about 10 to 25% of the time. And this is in adults. JVD is present 50 to 75% of the time. And muffled heart sounds are present about 25% of the time. So in the POCUS era, we don't wait for Beck's triad to make a diagnosis of tamponade. Pericardial effusion and cardiac tamponade is a POCUS diagnosis. All right, the next case is a rule out sepsis case. So here we have a lethargic 2-week-old who had a birth history was unremarkable, uncomplicated pregnancy and delivery. Mom was GBS negative, but this 2-week-old presented with some lethargy and some hypothermia. So the rectal temp was 35.1 degrees Celsius, was feeding poorly, vomited once, and he was seen at one of our community hospitals. That's about a 20-minute ambulance, 15 to 20-minute ambulance ride from us. And so instead of initiating any workup, they said, this baby looks sick. This baby is cold. They called us, and this was actually 3 o'clock in the morning, and they had the child and the parents transferred so that we could do the assessment evaluation at our hospital. And made it to us okay. These are the vital signs. Only thing that was striking was the tachypnea. Was not cold for us, 36.8. And overall looked pretty comfortable. Even though it was tachypnic, it was like a comfortable tachypnea. Not quite periodic breathing because the baby was breathing pretty fast, just sort of at rest. But the lungs were clear. There was no murmur. Pulses were present. Abdomen was soft. The capillary refill was 3 seconds. And yeah, I think once you have an abnormal temperature, either be it on a 2-week-old above 38 degrees Celsius or 35.1 is pretty low from a hypothermia standpoint. Some folks will use 35.5 as a cutoff to think about sepsis. So this baby needs a lot. There's a lot of interventions that are expected, and for our sepsis patients, we aim to administer antibiotics in an hour. So baby needs a monitor, IV access, probably make sure that the glucose is okay, that the electrolytes are okay, that we're not dealing with some sort of acidosis or inborn error of metabolism. Needs a urine, needs a lumbar puncture, antibiotics, maybe an x-ray, maybe an abdominal ultrasound. I think 2 weeks is pretty young for intussusception, but I would consider it in lethargic vomiting infants. And then what about a POCUS? Is there time for a POCUS? Or where in the algorithm does the POCUS go? So what happened, I was maybe a first-year attending. It was pretty early in my practice. It's middle of the night. We prioritize the sepsis evaluation. We get bloods. They're sent to the lab. We do the urine. They're sent to the lab, and we get ready for the lumbar puncture. And then during the lumbar puncture, while the baby's on a monitor, we had to stop because had a desaturation to about the high 70s, and the little one required some supplemental oxygen. And at that point, we said, okay, let's grab our point-of-care ultrasound machine, bring it to the bedside, and let's take a look. And this is what we saw. Again, I apologize for our flipped parasternal lung access images. It's just the way we do at our institution. I think it's a bit of a Northeast regional. So I know that Brown does it this way too, and a couple of other institutions. So the way we do it is with the aortic outflow tract this way and the left ventricle over here, because right is right. So the indicator is actually to the right shoulder. So anyway, this is a parasternal lung, and you can see, kind of get a sense something is not good function-wise. I mean, the right ventricle is big. It's 1-to-1 with the left ventricle maybe a little bit bigger, but it's a 2-week-old. So some of that is likely physiologic. If I saw this in, say, a 3 or 4-month-old, I would think more about pathology, but in a 2-week-old, a big RV, it might still be sort of, you know, pulmonary pressures that are elevated after birth. And it takes a couple of months for this to sort of normalize, as we say. Yeah, but the function seemed a little bit off. So we said, oh, this is curious. Let's get a couple more views. Here's an apical 4. And this mitral valve here is, I don't know. I think it's like sputtering to me. And I don't see any movement whatsoever of the lateral wall of the left ventricle here. Again, we see this patient's getting IV fluids. Every once in a while, you'll see a little bright spot over here, which would imply what? That's a more higher level question. We have little air bubbles in the right side of the heart, but every once in a while we see one sneaking into the left right there. What else is going on in this newbie?
Shunting through an ASD?
Yeah, probably a patent foramen ovale in this case, just because you don't see much of this looks like it's relatively intact over here, the septal wall of the atria. But this is something that when we were starting out doing cardiac POCUS, we were reviewing all our scans with a cardiologist, and we didn't even know to look for this, to be honest. And essentially, it was a bubble study to look for right to left shunting, right to left communication. And so, that's a nice thing about being able to collaborate with others, and especially when we're starting out, having like true experts, true echocardiologists to point out things that a little bit beyond the scope of what we consider reasonable to teach from a cardiac POCUS standpoint. But anyways, good things to know and good things to learn. And then finally, our subxiphoid view, which to me clearly shows just this is a heart problem. This isn't. It is less likely this is sepsis. This is a cardiac etiology for these symptoms of poor feeding and lethargy and hypothermia. And then just to be complete, we always have our team do a vena cava view. Again, even in this 2-week-old, it's staying relatively normal, the size. I mean, maybe you see a little bit of movement here, but I think this vena cava lacks collapsibility in this baby that has some LV dysfunction. And so we repeated some blood pressures. The right arm was 106/82. The left leg was 79/63. And so we had a discrepancy. We listened to the heart again, no murmur. We felt for femoral pulses, 1+ pulses. But we had, based on the POCUS, we had our cardiology fellow come in at about 6 o'clock in the morning at this time to do an echo. And this 2-week-old had a critical cohort. So this POCUS could have very well saved this baby's life, just because we pre-detected the coarctation before there were absent pulses or before there was clear signs of shock or decompensated shock. So got prostaglandins, admitted to the PICU. And not only was this incredibly helpful just to get the specialists to the bedside ASAP, but it helped narrow the differential diagnosis. in PEM, as you know, we're dealing with possibility A, possibility B, possibility C, and they're all managed differently. But this POCUS really helped narrow the differential. And yeah, I've now my little ones that have hypothermia, I always do a point of care ultrasound as a screen. So easy to do. Okay.
Great case, Antonio. Can I ask a question? Have you added any kind of arch views into your repertoire? Because I've started
Yes,
to
so
do
I
them a
haven't
bit.
had another coarct. Thank you. So ArchView is outside of the scope of what we say for POCUS, but and at that time, I to be honest, we weren't necessarily keyed in on coarct as a diagnosis, but for sure, if I have another case, the ArchView, you come above the clavicle, and you sort of look down and try to find the aorta. And that's Dr. McCurry. That's on my bucket list, is to just catch one before I retire. But we'll see. We'll see if I have the opportunity to do so. Coarcts, I'll see. It's one of these uh, relatively rare. For like not for PEM, but for we have a group of like 25, 26 faculty. So for us to be on the unit at the time that the newborn presents with a coarct, maybe once every 5 years, if you're lucky, every 4 to 5 years. We don't get them that frequently. Okay, so the next case, so we're gonna move from the cardiac cases here. We have a patient with altermental status, and you know what the altermental status bucket looks like. It's tox screen, neurological evaluation, hypoglycemia, metabolic. So it's a very broad differential diagnosis. I think she was about 5 or so. This girl was sent to us from another hospital after having a pretty large workup, and this is what our nurses type in our computer. So lethargic, dehydrated. This was the referring hospital, vomiting, got some IV fluid, antibiotics, X-ray, CAT scan. So this kid and this family, they've been through a lot already. Yeah, she was 5, so she had initially presented with some vomiting and some cough. Never had a fever, and yeah, I guess she looked unwell at the referring hospital. Did have a leukocytosis. Her glucose was fine. They did a head CT that's negative. They did a chest X-ray that was negative, and then she was transferred to us. She had gotten some IV antibiotics. We were worried about sepsis, but she looked so ill, but she didn't have a fever. And she got signed out to me in the morning, but we didn't have any hospital beds. So she would theoretically board in our DED for many, many hours before getting admitted. And she had already been in our emergency department for 6 hours before she got signed out to me. And these were her vital signs. So they look pretty good. Some tachypnea. Yeah, I give credit the overnight team that took care of her due to her presentation did do a cardiac POCUS, which was fine. The function's okay here, nice function. Apical 4, the vena cava is collapsing even after a fluid bolus, so it was pretty unremarkable. And then, yeah, she got signed out to me, and it was funny. It's like the X-ray was read as negative, but somebody had seen something, or there was something that maybe was atelectasis on the left side. And this was a hospital, we couldn't pull up the images, so it was all by word of mouth. So I said, I'll just do a lung ultrasound just in case. It's actually really something. And this was her lung ultrasound. So we used a linear probe at our hospital for pediatric patients. We get really, really nice images with the linear probe. Depth here is 5 centimeters. So if you look at the ultrasound probe as it goes from the diaphragm to the axilla, so diaphragm up to the axilla, that corresponds with the image on the screen. So we have spleen, pleura, spleen, spleen, pleura, spleen. Well, she doesn't have 2 spleens, but there's something that has the ecotexture of a spleen very high up in the left axilla. And so if you didn't bring her arm all the way up and scan all the way up to the axilla, you presumably would have missed this spot right here. And if you just put your probe right there and focus it in this area and just sort of scan around, you can see it looks more homogeneous than we typically see. I would say for pneumonia, we talk about hepatization, we talk about fluid-filled bronchioles, we talk about dynamic or bronchograms, which I think if you would have had the probe still maybe down here, you could have seen some dynamic or bronchograms over here, but the probe sort of fanning in different directions. Clearly a little shred sign here, but yeah, we have a diagnosis now. So it's no longer an unclear diagnosis, admit for monitoring and reassessment. Now we know what's going. This girl was vomiting and lethargic and had leukocytosis. She had pneumonia. Nice focal consolidation. And yeah, we actually reassessed her. She woke up. We gave her something to eat. Clearly went over the ultrasound images with the family and sent her home. We did some oral antibiotics. She had already gotten some broad spectrum antibiotics and called the next day because, you never want the patient like this to bounce back. We did a phone call and the dad was very happy. We amoxicillin, azithromycin, she was doing better. And she had full recovery after a pretty intense ED experience. But yeah, POCUS saved an admission in this case. And, x-rays are limited for pneumonia, and even the ones that sometimes have multiple diagnoses by viral pneumonia cannot rule out evolving pneumonia. I think they get a little bit vague sometimes. So love some old lung POCUS to evaluate for pediatric pneumonia. Okay, next case is a newborn in respiratory failure. See how we're doing on time. Oh, I think we're doing okay. I have about 8 cases, so looks like we're going to be just right. So this is a 2-day-old. We don't see a lot of 2-day-olds in our ED every once in a while, but a 2-day-old in respiratory failure usually doesn't come from home. They're usually in the hospital and they end up in the NICU. But this was a parent that wanted an early discharge from the hospital, so it was in the hospital for 24 to 36 hours. They were first-time parents. The baby was 38 weeks old. No issues reported during the pregnancy. And then at day of life 2, went to the pediatrician's office to get a weight check and just sort of the first outpatient visit. And the baby looked blue and the oxygen saturation was 30% on room air. So certainly a depends moment for the pediatrician. So they placed the 2-day-old on a non-rebreather mask, 100% oxygen, and they called 911. And then came to us pink. Actually, the SATs came up to 100%. Was no longer cyanotic, but very irritable, crying a lot. And we brought this little one into our major treatment area, assuming something was something pretty serious was going on, and didn't remove the oxygen, so satting 100%. But on the non-rebreather, pretty normal vital signs. The respiratory rate 66 for a 2-day-old. I guess it's somewhat elevated, but again, this kid was crying and irritable, grunting as well. So this baby clearly gets the works from a POCUS standpoint. And start with the heart. What do we think about the heart assessment here? Dave, you want to select somebody to go over these images?
Yeah, certainly. Go on, either Nigel or Bethany, you have a little go. It's all good here, all friends.
Yeah.
I think I'm not used to looking at it in your orientation, but the right ventricle looks quite a bit big, so it was the same size as the left.
Mm-hmm.
I can't see any fusion or anything.
Agree. And the function looks good, but again, in a 2-day-old, this is probably physiologic, and unlikely this is, RV. We think the 2 main things: an acute RV enlargement or RV strain pattern is a thrombus, a PE, which is unlikely for a 2-day-old. And in older patients, if that's ruled out, some persistent pulmonary hypertension, I'll think about cases like that. But again, a 2-day-old, this is like just likely physiologic here. So yeah, this looked pretty good. I was worried I'd see some completely anomalous, looking heart anatomy, but this all looks as we expect to see it. Here's a vena cava that's collapsing completely as the baby's crying and breathing in. You can see it right there, nice full complete collapse. And so we turn our attention to the lungs. This is the right side. And yeah, I would say there wasn't any transient tachypnea of the newborn reported after the delivery. This was a baby that was just in the well baby nursery right off the bat. So it was interesting to see these B lines on the right side. But finally finding something that looks abnormal. Here's the pleura. And yeah, this is certainly something that would raise eyebrows as to, is this a primary lung issue or what? And we turn our attention to the left side. You see this?
Nice.
Yeah, it's wild. I couldn't believe what I was seeing. I was like, really? So the probe was, this is about, so the diaphragm's like right here. So this is fairly low to mid chest, so T4, T5. So look, the pleura is just stuck, right? There's no lung sliding. It just looks really bright and stuck. And so you can actually, so over here, you have diaphragm. This is a spleen. And over here, you can see lung point right there, right there. So yeah, you see a little bit of shimmering here. Yep. And over here, this is all pneumothorax. And I saw this, I just got an x-ray that, probably could have confirmed with M mode, but motion mode, just trying to expedite things, working by myself. This was like 9 o'clock in the morning, something like that. And this was the x-ray. And so the x-ray to me was incompatible with the ultrasound because all we see is a little pocket of air between the diaphragm and the lung tissue here, but it looks pretty good. And it's a portable, the baby's supine, so there's those limitations. And then I'm debating, one little voice in my head says we should probably intubate this little one. Intubating a 2-day-old is not my idea of fun on to start a morning shift. A lot of people, I think, would go to non-invasive positive pressure. That would, before the x-ray, before like doing a POCUS or before x-ray, just from that degree of distress. But probably would have made things worse, and we're talking about a crash resuscitation. So I called the surgeons, our pediatric surgeons. They're wonderful. To be honest, they're really great. I said, I have this baby sick, 30%. SATs are up. I see a pneumothorax on ultrasound. Looks pretty big. This is the x-ray. Surgeons look at the x-ray. They said, eh. They sort of gave a little bit of a shrug over the phone. They weren't that impressed. And I was trying to escalate the urgency because just based on the POCUS. And they said, why don't you repeat the x-ray if you're that worried, and we'll be by to see it, shortly after. And so within 30 minutes, this is the repeat x-ray. I laugh because I cannot make this up. You see everything. Mediastinal shift to the right. And this is what we saw in ultrasound, right? This whole area here of absent lung sliding and that tension pneumothorax right there. So gets the pigtail, little light sedation, does well, repeat the POCUS post, and there's B-lines everywhere. Like, what is going on? Doesn't make any sense. So this was certainly a diagnostic dilemma in a pretty sick newborn. The final diagnosis ended up being surfactant surfactant inactivation syndrome with associated tension pneumothorax, which we're talking about case reports for full term. Like this is something, it's like a 27-weeker problem or a 29-weeker problem. But for a full term for this to go on to have surfactant inactivation syndrome with associated spontaneous tension pneumothorax, it just wasn't even in my differential diagnosis for this 2-day-old. And now it is, but all thanks to POCUS. And then the other thing I will say, there will be some times where you do a POCUS and you see something that you're sure is going on, and the follow-up assessment or a follow-up imaging, especially when you're talking about x-rays, maybe doesn't jive with your POCUS. Just trust your instinct and trust your gut. And the great thing is that you can repeat it. You can do it again, and sort of try to troubleshoot these diagnostic dilemmas that way. Anyways, this was a mind-blowing case. Baby did fine, and I have a new zebra in my differential diagnosis for the acute hypoxic respiratory failure in a 2-day-old. All thanks to POCUS. All right. Here's a case of undifferentiated shock. We have an 11-month-old with non-bilious vomiting. This is every day, all day. Diagnosed with gastroenteritis the day prior. Probably doesn't look that sick. And represents in 24 hours, looking quite ill. Labored breathing, lethargic, hypoglycemic, and terrible vital signs. Has an oxygen requirement, 5 liters, lethargic, weak cry, cyanotic before the oxygen requirement. Abdomen is distended, poor perfusion. The differential is badness and could be anywhere. So this is perfect case for rapid ultrasound for shock. Always start with the heart. I just think it makes sense logically to start looking for function. Looks pretty good. Some tachycardia, hyperdynamic. It's not a cardiac issue. Vena cava is collapsing completely. Likely some dehydration. And I'm not going to show you all the lung images, but yeah, did the heart, look for some pneumonia hiding out, lung bases, everything looks fine. Do an x-ray. And yeah, this x-ray isn't normal. So we have lungs, heart size looks okay, lung spaces look okay. And we got these air fluid levels. Boom, 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 boom. So looks like this is a problem in the abdomen. We turn our attention there to the pediatric pipe. So for adult patients, the pipes that we talk about for the rush protocol is usually the aorta, because adults get aortic dissections and abdominal aortic aneurysms. But the pediatric pipes that cause a problem is usually the bowel, is the gut. And can anybody see something here? This is just a right upper quadrant fast view, looking for free fluid, but can anybody shout out the diagnosis that you can see on these 2 images?
Someone's got it already. Didn't need to jump in.
Is it in the
It's in
chat?
the chat.
Sorry.
Sorry, you can't see it.
I don't have the chat up. I'm so terrible with the chat.
It's all right. Someone,
it's in there. Great. Ileocolic intussusception. It's like probably my favorite topic in pediatric emergency medicine. So this was an abdominal catastrophe. And this kid's too unstable to go to radiology. Like, how are you going to make this diagnosis? You have an x-ray with air fluid levels, but no gross signs of small bowel obstruction. You can't send this kid to radiology off unit. I mean, this is either going to the PICU or to the OR. But POCUS diagnosed intussusception. And I would just just think about it. In the kids that aren't that sick early on, under 2 years, 90% of the time, ileocolic intussusception is under 2 years. So the infant with some vomiting and some belly pain, just think about it. Even their abdominal exam is benign, because early on for intussusception, you're not going to get gut ischemia. You're not going to get bloody stools. That's going to evolve over the course of days usually, and then delayed presentation or delayed diagnosis is associated with higher morbidity and worse outcomes. So just think about it early. Intussusception is actually an application that for POCUS that we have very robust evidence published to suggest that once you're trained how to do it, our ability to rule in and rule out this diagnosis is very similar, in fact, not inferior to radiology performed ultrasound. And this was a multi-center paper. I forget when this was published in 2021. So now, wow, that was 4 years ago. Wow. Yeah, so even if your pretest probability, even if my pretest probability is pretty low, I'll take a look. Just I know that if it's stuck, it's stuck, and it's a huge target, and it takes up pretty much 25 to 33% of the abdomen, sometimes more, and you're not going to miss it. And then at P2, that we just had P2 conference a week or so ago, the top article for 2024 was a nice paper from the Sick Kids folks, a POCUS first pathway to streamlined care for children with suspected ileocolic intussusception. So you even going beyond the diagnostic, test characteristics, doing a POCUS first pathway, looking at patients that also got radiology ultrasounds, it's a faster time to reduction and it's a shorter ED length of stay. It's a win-win. It's a win for parents. It's a win for the team. You can place the IV sooner rather than later. There's so many great reasons to do a POCUS first approach for intussusception.
So Antonio, if I can ask a few bits from the chat, if that's all right.
Yeah,
So,
please.
I noticed that was Mark and Alex's paper there. That was quite a nice study by the look of it. So they were just asking in the chat kind of where to place the probe for intussusception.
Yes.
And I'm heavily prepared for one of these. I've never had one.
Yes.
Love Abdo POCUS, love all of that, but yeah, yet to have one. I remember joining your group, and I think Henry was giving the talk, and he said up in Connecticut, he said he has a lot of Amish families come in, and he said they present very late, kind of out in the sticks, maybe present quite late, and he said he's had maybe 5 to 10 of these. So I thought that was really interesting. I've never had one, but desperate to get one.
Yeah, you'll get one. I mean, I have a talk that's just intussusception, and I go over all the different ways the kid's presented, and some of them are just also, they're just like you wouldn't think the kid had intussusception, but yeah. So the way we do it is linear probe, right lower quadrant, transverse, find the psoas muscle. So I practice is similar to the appendicitis. Find the iliacs, find the psoas muscle in round short axis, and that's your starting point. And then the way we do it is an inverted U. So you're in transverse, you come up to the right upper quadrant, you rotate 90 degrees, you come across to the left side, you rotate 90 degrees, and you come down to the left side. Other places will do the lawnmower, so they stay in transverse, right upper, right lower to right upper, come across to the midline, down, and so I'll do both. If I think a kid really genuinely has it, this is the right story. They're lethargic, they're vomiting. Most of the intussusception kids have some degree of lethargy. Either I'd reported at home they got better or in front of you. But they may not have like a tender abdomen. It's like a big difference for intussusception compared to appendicitis. So if I'm pretty concerned, I'll do both the inverted U and I'll do a little lawnmower just to make sure I'm not missing anything. And in the kids that I really can't believe that I'm not seeing anything on ultrasound, sometimes I'll have radiology take a look also. But the ones where it's like a low pretest and I'm just screening, that's how I do it. And then I'll let them go with peace of mind that I know that I looked. Where in a lot of these intussusception cases, well, not a lot, sometimes we sort of miss a window of catching it early. But yeah, I think you'll definitely pick one up. It's the most common surgical emergency in under 2 years. So I'm sure you'll And it's not a hard one to do. You know, the appendix. I mean, you guys are doing a multi-center study in appendicitis. Interception is going to be a piece of cake. It's just a matter of having that patient present. And I think this is the last case. I think there may be one more after this, but we have this phrase called ZOPOGO. You know, ZO for Zofran, PO for PO. You know, PO oral challenge. Have a kid drink something. Go home. And so this is a ZOPOGO case, which ended up being something else.
Interjection, Antonio. So I do this every week with you guys. I'm Googling every single drug trade name when I'm on the call with you guys, laughing. But I think is Zofran, is it omeprazole?
I apologize. Ondansetron.
Ondansetron. Sorry, yeah. Okay.
Yeah, the generic is ondansetron, and yeah, we call it Zofran with a Z. But yeah, I realize now that maybe not so clear. But yeah, we do this. We do ZOPOGO all the time. Assessment and plan, ZOPOGO, gastroenteritis. So this was a 3-year-old female, vomiting, diarrhea, and abdominal pain. She gets fast tracked. We have a fast track, not area per se, but there's some patients that get triaged to so one of our advanced practice providers. So we have PAs and APPs, and then they'll see patients independently, and they do a great job. And so this kid gets fast tracked to that group, and you know, they think that probably acute viral gastro, but the kid looked a little dehydrated, so they just for the dehydration piece, they initiated a bit of a workup, I think. The vitals were fine. Abdominal was distended. There was no mass. There was no tenderness. Oh, sorry. Okay. But no rebound. That doesn't make sense. I can't tell. I didn't do this initial exam, so I'm not quite sure. Overall, like a pretty benign exam initially, but the kid looked a little dehydrated. So, and I feel like we have little of a low threshold to pursue appendicitis. So we typically don't get a CBC first and then decide on doing the ultrasound. It kind of happens in parallel at the same time. So this was the ultrasound done by the radiologist, which is equivocal. They saw some of the appendix, not all of the appendix. There weren't any inflammatory changes. You know, they sort of write the question of appendicitis remains undecided. No definite inflammatory features, and that's the white count, 80% neutrophils. So not a helpful ultrasound, other than didn't give us any new information that we could really sink your teeth into and do something with. And gets an X-ray, and on the X-ray, there's some wall thickening affecting several small bowel loops. And then the radiologist wrote that the findings might be due to small bowel obstruction or ileus. And so I think because the radiologist wrote small bowel obstruction in the report, the nurse practitioner I was working with that day, she kind of said, "Hey, can you kind of think about this kid and take a look at this case for me?" And so even though the appendix ultrasound had been done by radiology, I said, "I'm absolutely happy to check it out. Let's bring the ultrasound machine into the room." And her belly was soft. I mean, she did look a little pale and listless is how I would describe her. But at the time of this ultrasound, she was very tolerant of it and not having too much pain. And so we like to teach POCUS to pelvis. So if I'm going in for an abdominal ultrasound and I don't have a diagnosis, start on the pelvis, curvilinear probe, find the bladder, and look around the bladder. And this is what I saw next to the bladder. Does anybody have any ideas what the heck we're looking at? Because I got to be honest with you. I saw this and I had no clue. I said, this stuff is moving around. With some color Doppler. So I was like, this is some mass.
Yeah, in the chat we've got foreign bodies. Which I think is very sensible.
Intraluminal, yeah.
Yeah, and I think, I'm not going to speak up because I think you might have done this case for me before, and it was pretty unbelievable. Pretty
Okay,
unbelievable.
I may have. I added this one yesterday because I said I have to include this case.
Yeah. Now the guys are
I
like
think
this.
I think the take home is this was a bladder scan.
Yeah.
This is a bladder scan. So, all right. So put some color Doppler. Nothing. No hyperemia. No flow signals. Get some more pictures. This is the bladder. This is the lesion next to the bladder. Yeah, I like the idea of intraluminal foreign bodies. Like, look at these things floating around in there, but they're not casting acoustic shadows. I think water beads, but water beads are usually full of pretty distal for water bead, but they're like hypoechoic on the inside. Yeah, it's really odd. One more set of images. Bladder. Looks like there's some back and forth movement, perhaps. And then this, maybe it tapers at the end there in hindsight. And so, oh shoot, go back here. So I called my radiology friend. I said, "Could you take a look at these images?" Because they're able to see them in the system. They couldn't see the appendix on the first scan. I'm seeing something I have no, very confusing to me. And the radiologist looked at the images like, yeah, there's very strange. We should repeat the ultrasound. Maybe it's sigmoid, something related to the sigmoid because it's so, left-sided and close to the bladder. And so had a repeat ultrasound, and they commented on the prominent midline fluid and debris filled viscous, which was not seen on the first ultrasound and was really driven by the POCUS. And this kid had a Meckel's diverticulum, and her exam kind of changed. So when she came back from that second ultrasound, she was way more like when the surgeon saw her, she had signs of peritonitis. So of course, like patients are dynamic and their exams change over time. And she went to the OR right away. And the surgeon came down after the case and said that had the Meckel's trifecta. It was bleeding, it was infected, and it perforated. And the bleeding was what we saw in the ultrasound. So we saw that structure next to the bladder was this dilated, really engorged Meckel's diverticulum. And those little white spots or white areas, it were clots of blood that were just swishing around intraluminal. So, yeah, like a pretty fascinating case. Focus pelvis first. There's no CAT scan for this kiddo, which is great. And then, patients are dynamic. And we're at the hour mark, Dave. So I had one more case, but only if there's time. Otherwise, you let me know. I can try to do it quick.
No, I think we're good, man. I mean, a lot of people will be on shift and stuff. So,
Yeah.
10 or so have had to go, and that's absolutely fine. But I think everyone else who's here is very happy to listen, man. So keep
Yeah,
going.
I'll do quick. So this was a potential anchor bias case, or it kind of was at one point. So an 11-year-old, diarrhea for a week, pain on and off, and then had a new fever. So it was the fever that brought him and his parents to the emergency department. And we do scanning shifts, so we do educational ultrasounds. Not everybody's at the same level, but we try to teach POCUS in a healthy way. And sometimes the way to do this is just to do educational scan shifts with the knowledge that they're going to get reviewed at some point. So we try not to miss anything, and we try to give our learners opportunities to improve their POCUS skills. So the POCUS faculty can't be in the ED 24/7. It's one of the just realities. Yeah, so this was again 11-year-old, diarrhea, new fever. Probably an educational shift to do a fast or to look for an appendix or whatever the learner wanted to do. And then these are the vital signs. And this is what's from a physical exam standpoint. All these things were documented in the medical record. Abdomen is soft. There's no rebound or guarding. There's no distension. Abdominal tenderness in the left lower quadrant. Extraordinarily low suspicion for appendicitis. Extraordinarily was written in bold capital letters. By story and exam, this appears consistent with viral gastroenteritis. So all sorts of gastro. The kid got IV fluids. They were going to send him home. but had an episode of vomiting. And based on for the first time, had an episode of vomiting. There might have been a little green tinge to it. Had some air fluid levels on an X-ray that was done. The radiologist read the X-ray as most suggestive enteritis, and the kid came in just to get IV fluids because they didn't want to send him home. But it wasn't a belly pain issue, an acute surgical issue. And these were the educational scans that were done that weren't necessarily looked at by a credentialed POCUS person. And so, yeah, this is a right upper quadrant view. We see right here, this is a positive fast. This is fluid by the tip of the liver, which really shouldn't see for just run-of-the-mill gastroenteritis. And then we have curvilinear probe just kind of looking in the bowel and the abdomen. Some dilated loops of bowel. Looks like absent peristalsis. So I definitely would consider ileus, but there's also transmural fluid or fluid outside of the bowel. So I'd be worried about bowel obstruction for sure in this case. But what's causing a bowel obstruction? This kid with diarrhea. So usually the post-viral diarrhea get an ileus. The kids with prolonged diarrhea, post-viral ileus is not an uncommon thing that we see. And here's the pelvis view. So the learner was scanning pretty quickly, as you can see. Here's bladder. But there's something that's shouldn't be there over here. Right there. This is the sagittal view. This is the transverse view. So there is something there and there that doesn't look like free fluid because it looks like it's sort of kind of has edges to it. And then look at this, bright with some shadowing. So that to me looks like maybe a stone. I mean, I guess it could be air, but I can just stop it just right. You can see right here towards the middle of that clip, looks like there's a little, maybe an appendicolith with some acoustic shadowing. So, and this fluid collection definitely looks abnormal. So what happened in this case, I come into a shift the next morning and it was luckily a little bit quiet. So I look at the images from the day before, I see the scan, and the first thing I do is, did they go home? Discharge or admission? And so admission, which is great because then I don't have to call the family back. Fantastic. And then the next thing I do is see what service they're admitted to. And they're admitted to medicine, to the pediatric service for IV fluids and serial exams. So I called the hospitalist and I said, you may want to get a surgical consult. Of course, the surgeons weren't that impressed based on everything that had been written, and the kiddo got a CAT scan, thankfully, which showed a perforated appendicitis with a pelvic abscess. And some of this we picked up on. Right, look at the bladder. Focus the pelvis. Just look behind the bladder. So yeah, this POCUS was super helpful, even though it was an educational POCUS. And it's one of the reasons why QA is so important, I guess, from a patient care standpoint. Had interventional radiology drain the pelvic abscess and had an interval appendectomy. Usually do it 2 to 4 weeks later here. So my take-home points is that POCUS is a powerful tool for rapid diagnosis and management, early identification of pathology changes clinical decision-making, trust your findings, abnormal POCUS should prompt action. When you can use a structured scanning approach, scan with a plan. POCUS can expedite care, avoid unnecessary delays, and optimize patient outcomes. And that is my talk. Thank you so much for the invitation and for listening.
Antonio, amazing. Thank you. Such interesting cases. Does anyone from the group have any questions? Don't be shy if you do. Now's the time. I thought they were excellent cases. Really like the last one. It's just, you never know what you're going to find, and clinical examination alone is only taking us so far these days, isn't it? We're living in 2025. What's it Alex says? We shouldn't be playing checkers, we should be playing chess. And I just think you know, as an extension of your examination, as we always keep saying, it is just so important, isn't it?
Mm-hmm. I can't work a shift without POCUS, and it would be heartbreaking. It would be so difficult. Like if you took the machine away from me at this point, I said, okay, or like, what am I supposed to do then? Absolutely.
So true. Even away from abdominal scanning, echo, lung, even just for me, musculoskeletal now, I couldn't. You know, there's so much that I now know that I can't answer without it.
Mm-hmm.
So yeah, no, it's great. So let's keep spreading the message, I guess, with meetings like this. Thank you for everyone who's turned up today. It's great that you've given your time. And Antonio, it's been great having you. So we're definitely going to get you back after the summer. Is that all right?
Sounds great. Maybe we can do interception if there's an interest.
I think there would be, of course, definitely. I think, you know, people can use that as a starting point to then think about picking up a probe, having a practice. Because as you say, the technique for it doesn't seem difficult. I've queried it a lot of times. Just yeah, it's even non-POCUS wise. I think I've only had 3 in my entire career, and that's since 2009. So I haven't had loads. Maybe it's just. I don't think many of my colleagues have had it a lot either, but maybe it just presents in pockets, or maybe we expect to see it more often than we do, and then we're subsequently disappointed. I don't know, but awesome. Now, well, interception would be great. Anything you want to share would be really good. So thank you, everyone in the chat saying thank you. Right, guys, awesome. Yeah, and Antonio, enjoy the rest of your day. It's just the morning for you, and everyone else enjoy the rest of your working day or whatever you're doing. So we'll see you guys next month in a few weeks' time. Take care. Bye-bye.
Thank you. Bye-bye.